hematomas, try to prevent infections, but use of drains are a double-edged sword, and certainly the drain itself can serve as a conduit for infection. And then we know it also leads to increased blood loss and need for transfusions. And then, of course, the dreaded complication of a retained drain, which sometimes happens. It gets sutured in, and you have to take a patient back to the operating room. And then it can also decrease mobility, create some postoperative discomfort. And so the question is really, where's the evidence for drain use in spine surgery? So we're going to try to delve into that. And then also with preventing deep venous thrombosis, we want to understand a little better through our literature, what's the safest way to use these and avoid our other complications, such as epidural hematomas or even subdural hematomas, intraparenchymal hemorrhages in the cases of spinal cord tumors that have been operated on. So we're going to start with Dr. Pivazyan, who's going to look at use and outcomes of wound drains in spinal fusion for adult or for adolescent idiopathic scoliosis. And then he'll also discuss a second paper on the utility of prolonged prophylactic antibiotics in the use of wound drains following spinal surgery. And that's a systemic review and meta-analysis. And then Dr. Cobourn will discuss prophylaxis, pharmacoprophylaxis for venous thromboembolic events in spinal surgery, and that's a systemic review and meta-analysis. And then we'll come back to the drain topic with Dr. Cobourn closing with a study, a randomized study on closed wound suction drainage for extensive lumbar spine surgery. So with that, I will hand it over to Dr. Pivazyan.
All right, very good. Thanks, Dr. Sandhu. You hear me okay? All right, great. So the first paper is on the utility of spinal drains in adolescent idiopathic scoliosis surgery, published in Spine in 2012 by a multi-institutional group from the US and Europe. This is a retrospective review of a multi-institution prospectively collected cohort. The patient population is late onset adolescent idiopathic scoliosis patients undergoing posterior spinal fusion between ages of 13 and 21. The intervention group was the use of spinal drains. The comparison group was no drains. The allocation of arms, there was two groups of surgeons, those who routinely use drains and those who routinely do not use drains. There were four primary outcomes. They were all complication categories. Category number one was wound infections, dehiscence. Number two was neural complications such as radiculopathy, cardiac one, and CSF leak. Number three is other infections such as pneumonia, UTI. And number four was other complications such as reoperations, implant failure, restorative distress, etc. So group A, the drain group, had 324 patients with 36 surgeons. The no drain group had 176 patients with 14 surgeons. As far as the pre-op characteristics, they were pretty well balanced between the two groups. In terms of mean age, number of females, BMI, type of the curve, they're all pretty similar with no statistically significant differences between them. There was no cases of osteotomies. They were all primary deformity correction cases. The mean level fused was approximately 11 in each group. So jumping to the results of primary outcomes, this is the incidence of wound infection. There was no statistically significant difference at any of the time points. Essentially, they had several follow-ups before discharge, early post-op, late post-op, 1 year or 2 year post-op. And then at any time, the bottom row shows overall infections. The total number of infections at any time were 6 out of 324 in the drain group, or 1.9%, and 5 out of 176 in the non-drain group, or 2.8%. And this difference did not reach statistical significance. Next outcome category was neural injury, and there was no differences here either. So again, neural injury was defined as cauda equina, spinal cord, epidural hematoma, radiculopathy, or a CSF leak. The drain group had 2 nerve injuries, 1 spinal cord injury, 1 CSF leak, while the no drain group had 1 CSF leak, 1 nerve injury, and 3 cases of radiculopathy. When analyzed separately, the radiculopathy rate alone was significantly greater in the no drain group, but as a category of neural injury, there was no difference. The third complication group is the other infections category. Again, no difference here. 1 UTI in the drain group and 1 pneumonia in the no drain group. And lastly, other complications group. Both groups had 4, again, no difference. Both groups had 4 reoperations each, though the no drain group was nearly twice as smaller, the group number. Either way, the difference did not reach statistical significance. It is unclear what the indications for most of these reoperations were based on the paper. And then they looked at some secondary outcomes that they didn't necessarily define as primary in the method section, and one of them was transfusion rates intraoperative and postoperative. In terms of intraoperative transfusion requirements, interestingly, more patients in the no drain group received transfusion. The opposite held true for the postoperative transfusions. More patients in the drain group received transfusions. However, when they combined them all together, overall transfusion incidence did not differ. That is intraoperative and postoperative. They also looked at the effect of drain location on the postoperative transfusion incidence, whether or not subfascial, subcutaneous, or combined drains made any difference. Patients who received both superficial and deep drains were most likely to be transfused, followed by patients with deep drains, and then lastly, followed by patients with superficial drains. And then a few of the other outcomes were operative time. So the drain group had less operative time. They didn't specify why this was, but presumably this could have been because the no drain group, people take, surgeons would take more time in achieving better hemostasis, knowing that they're not going to leave drain. So the no drain group had a mean of 306.9 minutes, whereas the drain group was 275 minutes of operative time. There was slight difference in the fusion levels. The drain group was 11.7, no drain 11.2. And like I already mentioned, there was less radiculopathies in the drain group. The EBL was equivalent in both cases. And then towards the end of the paper, they did survey of all the participating surgeons as to why they use the drains that they do. Out of the 50 surgeons, 36 surgeons were drain users, and the rest of the 14 did not use drains. So of the ones that used drains, half of them just did use drains just out of habit. 18 surgeons, the other half, used specific criteria for needing to use a drain, such as excessive bleeding, presence of open vertebral canal, osteotomy, or revision cases. In terms of drain location, most surgeons use deep or subfascial drains, so 21 out of the 36. The rest use 15, and some combination of surgeons use both. And then importantly, criteria for drain removal. So half the surgeons used drain output as their criteria for drain removal as less than 30 cc's per day. And the other half of the surgeons used a predetermined length of drainage time. So most surgeons use 48 hours as their cutoff. 2 surgeons use 72 hours and 1 surgeon used 24 hours. So in summary, this is a retrospective review of 324 patients with drains and 176 patients without drains that showed no difference in any of the primary outcomes. That is wound infections, dehiscence, other complications, and other infections. There are some trivial differences in the secondary outcomes, such as when patients need transfusion, but overall transfusion rates did not differ. There was the equivalent amount of perioperative transfusions. Yep. All right, that's it for my paper.
Yeah, thanks.
Okay. Did they look at all at how often surgeons assigned to the drain group didn't actually use the drain and vice versa?
They didn't delve into that. It sounds like whoever is a drain user almost always used a drain, and whoever was a non-drain user just did not use a drain.
Yeah, I find that's one of the more interesting things in this paper to me is the kind of the survey amongst surgeons, the usage of drains, and you know, some just use it routinely out of habit, and then you know the others have you know specific criteria. I think myself I fall into that probably specific criteria category. But certainly, I'm very nervous not leaving a drain in like a cervical laminectomy case. But you know, I don't know the evidence. I mean, this is not necessarily comparable to that, but I think more evidence-based information would be helpful. I mean, certainly there were no revision surgeries for epidural hematomas in this study, which is important to know, and no infections with drains or without. So I mean, those are helpful pieces of information. But I do remember in the past having dinner with some surgeons from London, and the topic of drains came up, and these were clearly no drain users, and it became very interesting that my use of a drain in certain situations was somewhat comical to them. So I think surgeons' opinions of drains are interesting and not really based on any literature. So
This is a great topic. Thank Dr. Pivazyan for that. Jens Chapman in Seattle again. So just methodologically speaking, this is an interesting paper because it again touches on one of those things that we all do reflexively or culturally based on our historical memories. Did you see any power calculation in this? Because again, while 324 patients sounds pretty cool and the variables look all reasonable, both primary and secondary outcomes, was there power calculation?
Yeah, they did some tentative power calculation with, with assumed incidence of complication rates up to 8 to 10%. And if they had approximately 450 to 500 patients, then they would note difference. However, the complications ended up, being less than that. And this was, sort of after the fact, but it's certainly underpowered to notice a difference. If you have two infections versus 4 infections in this group, you're definitely not going to find any difference with this power.
So this is an interesting paper also because before we apply any insights of equipoise to the general population, this was an adolescent population, as I remember. And again, one of the biggest variables for us in everyday life that we struggle with are the adult anticoagulated patients. And I know you're going to touch upon that later. But again, right there, we have one of those things with pretty heavily medicated patients with multiple different comorbidities. And that was clearly not reflected at all in this target population. And the second thing is the infection rate, for instance, just to go at that in this adolescent population, based upon Daniel Sakatos and Larry Lenke's own publications, should be about 5%. So if I just extrapolate from 176 patients roughly in each group, you basically probably have to have almost tenfold patients to kind of just on this variable draw a calculation. And VTE, again, in this population is almost non-existent. So you can probably exponentiate the power needed to draw a calculation on VTE events even higher. So I think I agree with Dr. Sandhu. The key thing for me was the actual kind of a survey mode of this. And I too spent time in England, and I remember it's just a different culture, and some of our practice is clearly a cultural reflection. And if we don't put a drain into a major fusion surgery, there's a problem. The second guessing will be pretty profound in this country.
All right, thank you for all the comments. I'll move on to the next topic, which is related to drains, but more in preventing the infection risk that the drain themselves can cause. So many surgeons use prolonged prophylactic antibiotic course in an attempt to prevent infections that the drains potentially pose. So there's been several studies that compared 24-hour only antibiotics versus prolonged antibiotic course, and to see whether or not either one of those interventions reduces the surgical site infection rate. And all of those studies, primary studies, had suffered that main shortcoming, which Dr. Chapman mentioned, that was power. In order to find, and this is a problem with many of the infectious disease literature, to find statistically significant differences, you need patient numbers that are almost greater than 1,000, if not in thousands. So this is a systematic review and meta-analysis published in JNS this January that investigated whether a prolonged antibiotic course for spinal drains can reduce surgical site infection rates. The patient population was composed of adults undergoing posterior spinal surgery involving a closed suction drain. The intervention group involved patients receiving prolonged prophylactic systemic antibiotics, or the PPSA group. The comparison group were patients receiving 24-hour or less prophylactic antibiotics, or the non-PPSA group. The primary outcomes were deep surgical site infections. The secondary outcomes were superficial surgical site infection rates and overall SSIs. This is a selected list of inclusion and exclusion criteria. As far as the study design, these were retrospective or prospective studies. While any study that was non-comparative with a single arm was excluded, the approach was posterior or anterior posterior, cervical or thoracolumbar spine. Cohorts with anterior-only approaches were excluded. The population was adults. The conditions treated were degenerative spine, deformity, and trauma. Studies on osteomyelitis and tumors were excluded. The literature was searched in the databases. Approximately 2,500 titles were retrieved, and after the application of inclusion and exclusion criteria, a total of 7 studies were selected for meta-analysis. This table is the summary of all 7 studies included in the meta-analysis. There were 3 randomized trials and 4 retrospective studies. All papers involved degenerative or deformity patients, except for one, which involved trauma population. Most were decompressions and fusions. 2 papers involved cervical and thoracolumbar, while the rest were only thoracolumbar. As far as the antibiotic duration in the non-PPSA arm, it was usually defined as 24 hours of ANSEF, unless allergic to it, in which case they did usually vancomycin. One of the studies defined the non-PPSA as intra-op antibiotics only. The PPSA was most commonly defined as the duration of the drain, which in turn was approximately 3 days. In 2 studies, the PPSA was predefined as 72 hours. Importantly, none of the studies was adequately powered to ascertain the benefit of prolonged antibiotics or the lack thereof. The minimum power required to do that would be approximately 500 to 600 patients total, assuming an infection rate of approximately 5 to 6%. Most papers involved no more than 300 patients total. This is a traffic light plot for bias assessment of the 3 RCTs included in the study. D1, D2, D3, D4, and D5 are the bias domains, which are essentially bias arising from randomization or missing outcome data or selection of the reported results. And then there was judgment criteria for the said domains, which would be either low concern in green, some concern in yellow, or serious concerns in red. None of the RCTs had serious concerns. This is a similar figure, but for the non-randomized studies, similar domains, except here there's 7 of them, and similar judgments, that is serious, moderate, and low in red, yellow, and green, respectively. Particularly Skarupa et al. Study received a few serious judgments for a few of the biased domains, primarily because of the fact that they didn't provide enough details about how the subjects were divided into each of the arms. And this is the crux of the matter. This figure is a forest plot of all 7 included studies, assessing the pooled odds ratio of deep surgical site infection rate. The number of deep surgical site infections in subjects in each study is noted on the right of the author names, which with events and total respectively. Below is the pooled number of events and subjects in from either of the arms. The heterogeneity of the studies, or the I-square, was 7%, which is considered to be good. In the PPSA group, or the prolonged antibiotics group, 45 out of the nearly 1,200 patients had deep surgical site infection. In the non-PPSA group, or the 24-hour group, 46 out of, again, approximately 1,200 patients developed deep surgical site infection. On the right side of the figure is the forest plot representing the odds ratio of deep surgical site infection. The vertical line is odds ratio of 1 or no difference. To the left of the line are the outcomes favoring the PPSA, and to the right of are those favoring the non-PPSA regimen. Note that the diamond, which represents a pooled odds ratio, crosses a vertical line, which means that the overall odds ratio for deep SSI is equivalent between the 2 groups. Parts B and C of this figure represents essentially the separate forest plots for the randomized trials and non-randomized trials. Here again, there's no difference between either arms. And then these are the similar figures, except for the secondary outcomes, there are superficial infections and overall infections. Again, no difference. And then the last table is the number of organisms isolated from deep infections, stratified according to the type of organism and antibiotic regimen. Only 4 out of 5 studies reported the isolated organisms. The importance of this is to look for any trends in the incidence of multi-drug resistant bacteria in the prolonged antibiotic group. It was impractical to do formal statistics with such low numbers, but there was a trend towards higher prevalence of MSSA, a more susceptible organism in the non-PPSA group. Coag-negative staph was also more prevalent in the non-PPSA group, whereas MRSA and Pseudomonas, they were nearly equivalent, maybe slightly higher in the PPSA or prolonged group. But again, there's definitive conclusion is hard to draw based on these low numbers. So in summary, the prolonged course of antibiotics or drain prophylaxis provides no added benefit in reducing wound infection rates. This is a level evidence of 1. Trend of greater prevalence of susceptible organisms in the short antibiotic group was noted. So, and importantly, to this date, there are no society guidelines on the necessity or just in general antibiotics for drains. So.
Yeah, thanks, Gnel. I think that's very interesting. I mean, another example of how I think we as surgeons tend to do things out of habit and not necessarily looking at the literature. So, this certainly suggests no benefit for using prolonged antibiotics, and we all know that unnecessary use of antibiotics can lead to other problems of selecting for resistant organisms, and so I think this is very helpful.
Dr. Sandhu, so in Washington, it's a very competitive climate, obviously very many bright minds there. Can you imagine, let me rephrase this, for decompression surgeries, is there any time that you would not give or give antibiotics if there's no primary infection present? What's your rule in regular surgeries? Let's say you have a diabetic and you do a 3-level decompression. And antibiotics still a factor there or not at all?
For just the surgery itself, yes. I mean, everyone gets antibiotics, but it's just the single dose preoperatively, which I believe the literature supports. Given within 60 minutes before the onset of surgery. We do not routinely give antibiotics following surgery, although there is individual variation in the use of antibiotics with drains in place. So I know at our institution, it's not uncommon for patients to receive antibiotics while on drains, but I think this contribution to the literature may change that practice as well.
Yeah, so this is, again, one of those great topics that you selected, and I appreciate it. And again, the same criticism of mine applies as previously stated, and that is, if I look at the ends involved, it's nowhere close to really being statistically sound. If we look at, for instance, that infamous topic of does vancomycin in the incision actually help? We've had tens of thousands of patients. If you look at the number of patients here, a quick survey, maybe there are 1,000 patients. So looking at our struggles, we have a state database that we used for this. We had like 18,000 patients in there, and we barely could scratch out differences between infections and no infections. So that's, again, my primary concern. But I think instinctively, and I see nothing to the contrary, it makes sense to stop our antibiotics within a 24-hour period. Jack Ziegler in Texas, are you live? I saw Jack on, but I'm not sure he is.
Yeah, just partially live electronically. Yeah. Can you hear me, Jens?
Yes, now we can hear you.
Good.
Now we cannot hear you.
Did you have a question?
Yeah, so prolonged antibiotics. I know you do more finite cases, but does TBI have a policy on that? Do you give longer antibiotics for bigger cases or a prolonged drain use or a prolonged wound drainage or something like that? Has your group come up with a consensus on that?
Yeah, unless there's underlying other pathology, like an abscess that you're treating ends, most of us will just do pre-op dose and then 3 post-op doses. And many of us are drainers, but again, as you said before, that's sort of a cultural thing. It depends on your training, what your last case did, or the worst case you've ever had where you should or shouldn't have put a drain in. So there's not good science, but most of us are drainers by training.
Great. So we can have a consensus: short antibiotics, yes. No suspicion. No support for prolonged antibiotic use. I think, despite the shortcomings, is a great effort, a very meaningful paper, and until something more powerful comes out, let's stop antibiotics after 24 hours. Fair?
Agreed.
All right, I unshared my screen.
All right,
just give me a second to share mine.
Yeah. All right, we'll move on to the topic of pharmacoprophylaxis for venous thromboembolism and spine surgery with Dr. Cobourn.
Okay. Is everyone able to see that?
Yes.
Okay, great. So thanks, Gnel, for presenting your 2 papers and getting us started on this. The first paper I'm going to be talking about is another systematic review and meta-analysis, this time looking at pharmacoprophylaxis versus non-pharmacologic prophylaxis for VTE following spine surgery. And so a little background to start. As we know, VTE, including DVT and PE, are significant sources of morbidity and mortality for our post-op patients, particularly our super high-risk patients who are predisposed due to their comorbidities or poor mobility at baseline. Although this has been sort of better studied in some of the orthopedic joint literature, the spine literature has actually pretty limited evidence looking at the benefits of chemoprophylaxis over some of the mechanical methods like SCDs or compression stockings. So surgeons are often just balancing the potential benefits against the risks of theoretical bleeding complications, kind of on a case-by-case basis. So what are the guidelines? These are just a few examples of the several societies that put out guidelines on this question. But really, there has not been any sort of clear consensus. I would say what most of these have in common is that they do recommend some sort of chemoprophylaxis for high-risk patients, which they generally define as someone with at least one risk factor. In those patients, when chemoprophylaxis is used, they generally are recommending low molecular weight heparin beginning 12 to 24 hours post-op, and often with a mechanical method as an adjunct. Most are recommending against the routine use of IVC filters, but then recommendations about routine screening and about the duration of the therapy are much more varied. Much like Gnel's first paper, when there aren't clear guidelines, there's a lot of variation out there in practice. So I did look also at a few survey studies to get a sense for what people are doing. And it looks like in practice, these studies show that most patients use chemoprophylaxis in trauma cases, especially when there's spinal cord injury involved. And about half of the surgeons are using these in their elective cases routinely. So for this systematic review, their initial search terms yielded 560 records, of which they included only full text articles and only those that had at least two arms comparing any pharmacologic prophylaxis to any non-pharmacologic prophylaxis following spine surgery. So they excluded those records that had abstracts only, were single arm, non-comparative, included patients with recent history of VTE and those in the pediatric population. Their primary outcome of interest was the incidence of VTE, which included DVTs and PEs in the post-op period. I made a note there that they did not distinctly define what that period entailed. And their secondary outcomes included post-op hematoma, other significant bleeding events, mortality, or any other adverse event related to anticoagulation. So their results, the table on the right is quite busy, but it includes the characteristics of the 7 studies that were ultimately included. 3 were randomized studies and 4 were retrospective for a total of 8,373 patients. I think the primary takeaway that I got from looking at this table is the high heterogeneity of these studies. So again, relatively low ends. And if you look in the comparators column, you can see that a significant variation in which pharmacologic agent was used is there. And then also a lot of variation in the mechanical prophylaxis used. So for instance, in some of the older studies that they included, they actually used Coumadin. And another study used aspirin, while the rest tended to use Lovenox. The types of procedures that were included were also highly variable, with some including all regions, some including only lumbar surgeries, only elective surgeries, et cetera. And then exclusions based on risk factors and indications for operating also varied between these studies. So a few of the studies excluded trauma and tumor cases, while others did not. I did not include the traffic light plot, but none of the RCTs that were involved had a low risk of selection bias when they assessed for that. So I think that's an indication that there may be some significant differences in baseline characteristics that could, present a potential confounder in these results as well. So on the right, we have the 2 forest plots from the meta-analysis of the included studies. And you can see on the top one that there was a statistically significant reduction in the incidence of DVTs in the chemoprophylaxis group, but that this effect was no longer significant when the data was pooled with the PEs for a total VTE rate. The authors did perform a sensitivity analysis where they removed each study one by one to see if that would change the significance of their results. And they actually found that when they removed the McLean study in 2017, that VTE number did remain significant. So the study has several significant limitations, a few of which I've already discussed. So, as with any meta-analysis, looking at a specific question, very few studies were ultimately included in the final analysis. And those that were included were highly variable in the pharmacologic agents that were used and the patterns or their arms of study. So for instance, some used pharmacologic agent plus mechanical prophylaxis versus mechanical alone, while others used chemoprophylaxis alone versus mechanical. There was also a high degree of variability in their method for diagnosing and screening. So some of the studies did routine screening for VTE at day 7 or prior to discharge, while others only obtained imaging if there was clinical suspicion. And then I think the inclusion-exclusion criteria across the included studies and the sort of failure to balance for comorbidities is probably one of the bigger issues here. So they included a variety of different procedures depending on the study and a variety of pathologies. And then the comorbidities is, as we all know, really important when we're looking at VTE because that's probably the most significant contributor to whether or not patients are likely to have this complication. So ultimately, this systematic review and meta-analysis found that there is a potential benefit to using pharmacoprophylaxis post-spinal surgery. However, due to a lot of the limitations we discussed and significant differences across practices, I think the overall quality and quantity of evidence remains low. And I'll pause here for any questions or comments.
Yeah. Let me turn the question to you guys at George Washington. So what do you do? And do you have consistency amongst the faculty, let's say in spine cases? Is every practitioner adhering to one standard of, let's say, starting chemical VTE prophylaxis within 24 hours on every patient who's an inpatient or not? What's your observation there?
Yeah, so we actually did develop a kind of practice-based protocol that we use at our institution. And so at Georgetown Hospital, everyone, basically adheres to this protocol unless there's a significant risk factor for bleeding. That sometimes we make variations. We generally would start our Lovenox within 12 to 24 hours of surgery on every patient, and they stay on that as long as they're inpatient. In addition to that, we also use SCDs and early mobilization best we can.
And do you want to comment on the screening Doppler program?
Oh,
also?
yes. So we've also, we routinely do screening Dopplers. So particularly transfers from outside hospitals or patients, with significant comorbidities, say they have a cancer history of some hypercoagulability or past VTE, we will get screening Dopplers on admission.
I congratulate you on having a consistency. There's a paper of ours floating around. I think we have about 2,800 spine patients. And again, we had it's not accepted yet, but we're like in our second rewrite of this, but it's, I think, pretty high quality data because it's very well screened. And yet again, this is one of those very difficult subjects because the post-discharge VT incidence is not trivial. And you mentioned something that's very important. That's a little detail, and that is post-discharge. So having some people on chemical VT prophylaxis and others not, who seem to be doing fine by discharge, and then end up with something. To catch those patients is actually quite hard. And we'd need to have kind of a true follow-through over about 3 months post-surgery or 90-day global period surveillance to have a true number of VTE events that are clinically apparent. So that's something that we found to be clinically very hard and that we in our own data gathering struggled with. But I congratulate you on having a homogeneous practice amongst your surgeons, because one of the reasons for our study was that we could not come up with a consensus, and there were very strong opinions about some and others, and infections, prolonged drainage, the drain presence, everything was quoted, and we did not find any of these factors to actually be relevant. So we completely agree with you in our paper that early institution of VTE prophylaxis is meaningful and safe, and that there were no epidural hematomas, and the epidural hematomas that did occur happened within the first 24 hours and were not related to chemical VTE prophylaxis at all. So those are some of our clinical observations, but the paper is not out yet, but it's a single institution, larger, well-controlled group. So, but congrats on having a consistent policy.
Yeah, no, I think that's great. Your paper will be very helpful in helping your institution and others, adopt a consensus on how to deal with postoperative chemoprophylaxis. But I think it's important, and it does make a difference.
Do you have a problem keeping patients on prolonged chemical VT prophylaxis, and what do you use outside of tumors and spinal cord injuries, where I think maintaining them is not an insurance problem, but people without a history of thromboembolism, we found it to be very hard to get insurance companies to put them on an oral anticoagulant, for instance, and it's simply not covered. And CMS here, at least in our region through Meridian, does not cover it.
I personally haven't seen too many issues with the insurance providers. I mean, I think if there's generally a clinical need, we can try to justify that and get it covered. But I'm sure the regional variations with the insurance systems are very problematic.
We also don't routinely send our low-risk patients home with anything. They stay on a low-dose sub-Q Lovenox while they're in the hospital, but then generally, unless they have a history or something very specific, we wouldn't send them home with it, which is probably why we have had fewer issues with insurance. We actually are also, so we've had a paradigm shift in 2018, I believe, where we shifted from sort of a more heterogeneous use of sometimes heparin, sometimes Lovenox, to primarily using Lovenox, and that's kind of where our new protocol came from. So we're actually also in the middle of data collection, doing a similar study to just look at our surgical patients since then too.
All right, great.
I'll move on to the next one. So we'll return to the topic of drains. So this study was a randomized study of closed wound suction drainage for extensive lumbar spine surgery. As we talked about a little before with Gnel's papers, surgical drains are commonly used following spinal procedures, but their benefits for preventing post-op hematoma or infection remains controversial. And so the authors in this study actually referenced a study that was published shortly before theirs that found that there were not any benefits to using surgical drains in single level lumbar laminectomies. And so they hypothesized that this finding likely be extended to larger surgeries. So 83 consecutive patients who were undergoing multi-level lumbar spine surgeries were prospectively randomized to two groups, drain or no drain. And so 42 patients had a subfascial closed wound suction drain placed and 41 did not. Patients with thoracotomies were excluded both from the randomization and from the data analysis. They looked at several continuous variables in both groups, including age, blood loss, OR time, pre and post-op hemoglobin and hematocrit, post-op temperature, and hospital length of stay. And then they also sort of came up with an ordinal system for looking at the amount of drainage on the dressing, which they compared via chi-square. So the results of their analysis, they found that there were no patients in either group who developed an infection, had a clinically relevant hematoma requiring evacuation, had compression of the cauda equina, or had any new neurologic deficit for the minimum follow-up period, which was 1 year after surgery. And so in their analysis, which you can see on the right, the only statistically significant findings that they had were a higher temperature on post-op day 1 in the non-drainage group, which resolved by day 2. So not particularly clinically significant. And they found that the number of patients who had heavy dressing drainage was higher in the non-drainage group as well. So the theme of the day, the limitation of the study, it's extremely underpowered. So looking at a rare event with such a small N, we're unlikely to find anything. So with an incidence of epidural hematoma less than 1%, infection being relatively low but more variable, and only 83 patients total randomized, they weren't able to find anything statistically significant, which is in their primary outcomes at least, which is not surprising. They actually acknowledged this themselves, and in the discussion note that they did do a calculation to find what their population would need to be to power the study to 80%, and it would have needed to be over 9,000. So they sort of stopped there at a more feasible size. Another thing is that they really didn't account for any comorbidities or risk factors. Although I do think the problem with the underpowering of the study is probably more significant. Because that study is a little bit older, published in the early 2000s, I did also kind of want to touch on some things that have been published since. And so this is a newer study out of Rothman in 2023. That looked at drain duration and output effects on readmission. And so they looked at almost 1,200 patients, and they did not find that any of the drain variables had any effect on readmission after lumbar surgeries. And so you can see here, their ROC curves show that all of the drain-related variables are poor predictors. Another one that looked at this, 420 patients were randomized after a single level lumbar disc. And they found that the incidence of post-op fever was higher in the non-drainage group, and immediate post-op pain scores were lower in the drainage group. The only other significant finding that they had was, not surprisingly, that the rate of transfusions and blood loss were higher in the group with the drain. And then finally, this meta-analysis of 5 studies, which included about 1,300 total patients, found that there was no difference in the development of a hematoma, reoperation, or infection, but they did also find a difference in blood transfusions and post-op fever. So in the study that we were looking at, the presence of a drain did not alter the clinical course or the incidence of hematoma or infection following extensive lumbar surgery, which again, they defined as anything more than a single laminectomy. And again, in the absence of clear, high-quality evidence, this issue of whether or not to use a drain will continue to be sort of an issue of surgeon discretion.
Yeah, thanks, Kelsey. I think it's an interesting paper, but like you said, very underpowered, and I think we're at the end left to just decide amongst ourselves based on our practice, based on our training, based on our last complication. So I think as surgeons as a group, we tend to be a little bit superstitious about complications. So I think, we're often guided by our own complications and what we do next. And but I personally, I've never been able to pick correctly when to use a drain in the case of like a lumbar laminectomy, for example, a minimally invasive decompression. And we've looked at this in terms of hematoma rate, and it's about 2% with tubular laminectomies in our experience, looking at several hundred cases. And I've never really been able to pick properly who should get a drain and who shouldn't. And so typically I don't use a drain, and we'll see occasional epidural hematomas that require evacuation, but and I don't think I would change that because it doesn't necessarily predict, in my experience, what will happen, and I think maybe I need to reevaluate that for cervical cases as well, based on our discussion here. Curious what Jens, what you think of the use of a drain in cervical cases where the stakes are much higher for epidural hematoma.
This is Jens. So first of all, an apology to our colleagues at Georgetown. I've repeatedly misappropriated them, and it's of course Georgetown that we're so privileged to have here today. And I really apologize and appreciate Georgetown's eminent contributions. So I really mean my apology from the bottom of my heart to be considered. So thank you for this. The point about drains is an interesting one. Good morning, Randy. Thanks for pointing out my error. The variables that we're looking at are probably not all that well thought through. And I'd like to pitch that out back to my colleagues at Georgetown. That is albumin and quality of tissues. So if we have people with hypoalbuminemia and poor membrane stability, and patients who don't mobilize, we have a very different situation from people who get up, who are able to prone, who are able to ice their wounds. The type of access obviously matters, and will they have anticoagulants on board? Are they on chronic anticoagulants, which again changes membrane permeability? So these are the variables that I now, from what I've learned, would take into great consideration prior to making a categorical statement on drain or not. Medical legally, and Randy pointed that out, a drain in a larger surgery in this country is pretty much a SOC. I don't want to spell that out, just by convention and conviction rather than scientific data. So what are your thoughts on the variables of mobilization, rapidity, quality of closure? Again, the British laissez-faire closure comes to mind versus the very meticulous American closure, and rate of mobilization and general host factors.
I think, oh, sorry, go ahead, Dr. Sandhu.
No, Kelsey, go.
So yeah, I would agree. I think kind of the next steps will be, looking at things like frailty for diabetic patients, getting A1C under control prior to surgery if it's elective. And, you can, have someone see a nutritionist if their albumin is low, and sort of optimize them in those ways that maybe we didn't think about as much before.
Dr. Cobourn, are you going to put drains into your, let's say, 2-level lumbar decompression fusion patients?
I think it will probably depend on if there's any updates in the evidence. As of now, I would say my standard default would be most likely no, unless I see something intraoperatively that makes me concerned, or if they have some other significant predilection for bleeding.
Let me turn the question around, Dr. Pivazyan. Are you going to, 2 years from now, going to not drain your lumbar fusion patients that you've done?
In our institutions, we drain almost all fusions, but looking at the data, we're in the process of doing a pooled analysis of all these studies. There's far more than these, and if the data is not supportive or if it's equivalent, then at least I would say I would be inclined to not using drains, any more than I did before. So maybe for long fusions or decompressions, and not for the shorter ones.
Well, I think what some of this literature suggests is we underestimate the significance of tamponading bleeding when we don't leave drains. And when the wound is closed and you get a little bit of blood clot there, but it stops and it tamponades additional bleeding, unless maybe there's some predisposing factors that history of blood dyscrasias or being on anticoagulants before surgery and other variables. But I think, the fact that drains clearly show increased blood loss following surgery and the need for transfusion, I think really, makes me reconsider the significance of, tamponade to helping with postoperative wound healing and hemostasis.
Randy, as a pioneer of MIS surgery, are drains an anachronism now in your world?
Well, I've used drains for 40 years, but I would say they were big osteotomy type cases. But I'm going to leave those cases to Faheem now, since after 42 years, I just gave up my surgical malpractice insurance. So I'm going to stick to injections.
Very good.
Well, I want to thank our colleagues at Georgetown. Again, my apologies for the misnomering, and thank you, Randy, for pointing that out.
I'm sorry.
No, I appreciate it genuinely. I read off an Outlook entry that was wrong, so my apologies. But Georgetown did a terrific job in our department.
Yes.
Colleagues in Spine did a really cool job. And I, again, so appreciate that you picked up topics that are so relevant to our everyday practices, and they'll be on my mind as they go down. And I think getting larger databases would be really cool with controlled data that have a solid data cleansing effort behind them, and sharing that data openly, because that's how we can learn, that's how we can advance, and having meaningful spine registries that are owned and run by surgical colleagues like you, so we can really define standards of care, and being respectful of cultural differences also, like the UK bomb really hit home. So I thank you for that. Any closing comments, Faheem, from your perspective?
No, we really appreciate the opportunity. I think this was a great job by Gnel and Kelsey in presenting their papers, and appreciate the discussion. I think, like you said, it's something that we think about every day and do every day, but maybe don't discuss enough. So I appreciate the opportunity to share with everyone.
Thank you. Have a great Cinco de Mayo, and so good to see you in DC. And till next time, till soon.
Thank you.
Take care.
Bye-bye.
Be safe.
Thank
Bye-bye.
you.
Bye-bye.